bedside. Do you have your mic?
I'm just going to get a mic just in case. I'm usually really loud, but...
No, it was. I just turned it off. I just muted it.
Sorry. All right. Hi, everybody. As Tilley said, my name is Kim. I'm one of the RTs here in Edmonton, and today the talk was listed as nursing considerations, but more I want to talk about what happens at the bedside when we decide to put somebody on high frequency or a jet. Yesterday, Dr. King talked about somebody says, "Oh, we should put the stadium jet," and then stuff happens, and it shows up, and they go on the jet. So that's the piece I hope to talk to you, speak to you today. Everything I'm going to talk about is observational. What I've learned just being at the bedside, what I've learned from my colleagues. As Tilley mentioned, I've been in an educator position for the past 5 years. So I've been at the bedside as much. So a lot of what I'm saying is what I've learned from my peers. And what I've learned spending many hours on many nights, sitting in the bedside, watching the monitor, watching the baby, or what can we do? What else can we do? And the biggest piece, I think, is the human resources. The people around you that can look at a patient and you all come with different perspectives, different experience, and just have some ideas off of each other. So sometimes we get that vision where we are looking and we think we've tried everything, and it just takes that one extra person to come in and go, "Oh, did you guys try this?" Not so much, maybe we should have thought that. So the other human resources I want to speak about is primary care. So if you are using the jet or new to the jet, then now they're your people. They are fantastic on the way. They're learning great products at time, and they will walk you through situations. So that is a great resource as well. So when do we use it and why? This has been talked about a lot for the past 2 days, so I'm just going to touch on it really quickly. So anytime patients have been met with a jet at high frequency, and then you feel it. So it's going to be, we find it's very physician dependent. Some people like to start with the jet or start with high frequency. Some people prefer to start on conventional ventilation and then switch to the jet or high frequency. And one thing, again, this is purely my experience. So we want to, I think we need to stop thinking of these therapies as rescue measures and just different modalities and different modes of ventilation. So these aren't necessarily your sickest patients. They can be, of course, but this can just be the way we're treating them because of their disease process. So that's all I have to say about that. The whys, again, we've gone over all of this. The PID are air leaks and pneumonia. You can't fix them using conventional. You don't know what else to do. Putting aspiration, diaphragmatic hernia, PPHN, and the list goes on and on. So, what do we think about before we put them on? And I think these are, again, things we've touched on over the past few days, but I'm just going to go over them again. What we want to do is we want to make sure the BP is okay. And we have to do this with all modes of ventilation, but particularly we think about it when we're changing to high frequency, so make sure their blood volume is okay. If they need inotropic support to do that. We do go up on the mean slightly. Having said that, maybe we're not using optimal peak on conventional ventilation anyways. So make sure your BP is optimized so that we can alter our peak. Suctioning prior, both oral and through the ETT. I talked about oral suctioning. I'll talk about it a little bit more later about keeping the mouth clear because you do have a leaker on your ETT. There is some talk that you will get exhalation of CO2 out around your tube. So you want to keep the mouth clear. You want to make sure you have a large enough ETT so your pressure is actually getting into your lungs so it's not getting attenuated too much. Then you don't have too much of a leak so that the mean airway pressure is actually getting to your lungs we hope it's pretty close to what we set. And we want to consider previous checks, x-rays, and what our current mean RA pressure is. And everybody's talked about this a lot. Standard, usually 1 to 2 above what we're currently on, but we can consider what our previous x-rays look like on those mean RA pressures and make some decisions based on that as well. Assessing a gradient on high frequency is sometimes parts of it are certainly more difficult. Oscillation, right? It's my spelling error. Where is it? Show me fix it. Heart sounds, bell sounds, and breath sounds are something we can't really hear. I see people often put a stethoscope on the chest, and that's perfect. But you just really hear vibration. You're not going to hear a murmur. You're going to have a really difficult time discerning breath, heart sound. Bowel sounds often, maybe you can hear them. I'm an RT, so I don't do that very often, but you're going to hear vibrations through the infant's entire body, especially the really, really small ones. So you have to use different parameters to do your assessment. And mostly that's just looking at the chest x-rays. So depending on what you read in different units have different protocols, and I would caution you, I went through and looked at a lot of different units protocols. Many of them are very old, and many of them are based on one type of ventilator. So either the sensormatic, usually the sensormatics, and they speak about how often they want you to do chest x-rays and that kind of thing. I know that's not our current practice, and I'm interested to hear what other people's practice is. But when we're looking at the chest x-ray, we're looking for one of two things. Are we hyperinflated? So this is obviously a hyperinflated x-ray with compressed curve. So in an x-ray like this, we're going to want to go down on our knee. Or do we have low blood volumes? Or are we going to want to use a higher knee than we were previous? So if this is your previous x-ray, you may consider, maybe 4 higher rather than 2 higher, because you weren't at optimal peak to start with.
We should probably.
So you guys are so details. See? Come on. ABGs. So, again, every unit's practice is different. ABGs are fantastic. They're just a moment in time, and I would, my experience has been you can do a gas, and 5 minutes later your CO2 is in a 50, your CO2 could be at 100. So it's a moment in time and you have to use all the other numbers available to you and your patient to tell you what's going on. It's not going to, you can't just do a gas every 4 hours and sleep your patient. It's good that entire time. Okay, batteries? I can probably talk loud enough.
Yeah. Was it turned off? I just turned off the power.
It turned off.
A low
How?
battery.
Yeah.
Maybe just do it for now. Yeah, do it for now.
Oh, I can probably talk loud enough. Can you hear me? Yeah. I'm the oldest of 4 kids, so I can get my point across. So ABGs, again, a moment in time, and you're going to use all your other variables to determine, use it as a trend, and go from there. Chest wiggle, to me, the most important thing. You put your patient on, and you have to look at your patient. There is no, we've talked about it over and over and over, there's no one size fits all. You have a good, safe starting point, and when I talk to students, that's what I talk about. Put them on something that's safe, that's not going to be harmful, and then look at them and see which way you need to go. You need to increase or decrease your amplitude or your tidal volume if you're going that way. Chest wiggle, the video, your baby was prone, and I find it really difficult when babies are prone to assess chest wiggle because you're looking at the back. It's much easier when they're supine, but they like being prone. And then again, your blood pressure. So we, on our monitoring sheets, keep track of the blood pressure because we know if our blood pressure is poor, our gases are going to be poor. Probably not a lot of point if you have a significant drop in your blood pressure to worry about getting a gas. You know it's not going to be that good. You have to figure out why your blood pressure dropped, fix it, and then improve. get any more better? So suctioning, oral suctioning I already talked about. We got to keep the mouth nice and clear. We, in the neonatal population, are lucky. Well, we don't have cup tubes. So we do have air coming out through the mouth. We're getting rid of, eliminating CO2 that way. In pediatric and adult populations, they will, if they're having trouble with CO2s, deflate the cup and see if they can't eliminate some CO2 that way as well. So just keep up on your oral suctioning. Always use an inline suction catheter. I think that's probably pretty standard now, I hope. So we don't want to disconnect whenever possible. You want to maintain that mean. We do know when we suction, we are going to de-recruit. We are going to lose some lung volume, but we want to minimize that if possible. Our practice, if the baby is on the Sensormatics or the jet, is to have 2 RTs at the bedside. And that's simply because the machines can turn off if you suction for too long. And then there's kind of panic because the baby's not being ventilated, right? So we have 1 RT doing the suction, making sure everything's okay, and 1 kind of on standby. We only do it on a PRN basis. It's not Q2 or Q4. PRN at least once a shift to ensure patency, but that's probably going to happen anyways, right? So positioning and repositioning. Currently for us, we are using the jet and VNs or Leonis. We don't use Sensormatics hardly ever. So Sensormatics, I will say, is the most difficult to reposition. Anybody who's ever used it knows that. It makes the jet and manipulating babies on a VN or a Leoni or any type of other oscillator look pretty easy. So oftentimes you're going to put your PID or your pneumo down. We always, and again, this is our practice, keep the babies in a closed isolette at dark at all times, so we often can't see the patient. We want as much of the circuit in the isolette as possible, and that decreases the rain out. So you want this ventilator circuit inside where it's warm, so because any parts outside of the isolette, you'll get rain out, you can instill your patient, that type of thing. When you're repositioning, first thing you want to do is make sure you don't disconnect the baby. We've already talked about that. Ensure that your ETT is secure. I don't know if anybody else has tape issues, but we certainly have had some issues with our tape as of late, so you want to make sure your ETT tapes are good. Once you reposition, you have to reassess your chest vibration. We do get changes in leak when we move the babies, even sometimes moving their head from left to right. You'll get a large leak, you won't get as good chest vibrations, especially if you're using amplitude. When you're if you're manipulating amplitude for your oscillation. So you may have to manipulate your ventilator if you can't get rid of the leak, or if your chest has stopped rising. We like to suction usually after the reposition because moving them and they're crying and such, they tend to start coughing and bringing up secretions. And then the positioning of the lines, and this is particularly important for the jet, where you need to have the pressure line up. So there's a swivel on the adapter, and I can show everybody, right? So we reposition the baby, we make sure none of the lines are kinked, and we have to move the box as well, so that it's at the top of the baby's head, but that nothing's kinked and everything's clear. One other thing we find, and I think the mostly I've seen it on the jet, is we tend to get a little bit of condensation right in the end of the tube. And lots of times we'll suck it out before we reposition, because as soon as you do that, you instill your patient when you move them, and then they're very unhappy with you. Am I good?
Sounds like a lot of energy.
What's that?
Seems like a lot of energy.
Energy?
Yeah, talk about that.
No, I'm just loud. Sedation. This is a hot topic, I know, for us, for sure. Again, it's not a surgical unit that where my experience is. So it's sedation is used certainly in moderation. We want the babies breathing. We certainly don't want to sedate and paralyze them. I was thinking during the last talk, when I started this, would have been a very, very different talk. Everybody was lying flat on their back on a radiant warmer with hooked up to probably a star or something. And if we didn't like the mean airway pressure, we'd add some dead space to give them more, and we'd sedate them and we'd paralyze them and we'd see what happened. And now our practice has come so far from there, it's kind of interesting to think back. I don't even know if we'd be able to do it anymore. So we don't want the babies becoming narcotic dependent, and we want them breathing whenever possible. So you do want to use it in moderation, and we're going to talk in a little bit about different things we do to try and make sure that babies don't need sedation, and then give it if we have to. So the other monitors we must use when we're doing high frequency at any time is a transcutaneous. So we use our transcutaneouses on our jet because we don't have enough for all of our babies that we have oscillated. So if you're on a jet, you get a transcutaneous for the most part, if we have enough around. And they trend very, very nicely with your CO2. If you get a jump in your transcutaneous, you can pretty much assume that your CO2 has skyrocketed, so, well, jumped as well. So I generally try and fix the problem before I double check a gas. So if my chest has stopped wiggling, I'm going to look at my patient and I want to try and get their chest moving again, rather than get a gas to confirm what I already know that their CO2 is up. DCO2, this is talked about a lot, and this is why suctioning is so important in oscillation. It's that tidal volume squared piece. So if your DCO2 is inversely proportional to your CO2, and we tend to volume target oscillate now, so our DCO2 is very, very stable because our rate is set and our volume is set. So unless we aren't achieving our volume, there's no reason our DCO2 should change.
Which transcutaneous do you guys use on your study?
SEDATION we have right now. Yeah. So, but if you aren't using a volume targeted mode, anytime your volume drops even slightly, you have a significant drop in your minute ventilation, and then you will get a much more significant increase in your CO2 than you would with the same volume drop on conventional ventilation. So one of the things we find, one of the biggest things, is suctioning. We'll take care of that, like maintaining a really good pain airway. Of course, heart rate, fats, and BP, those are all things we're going to look at to try and, for the whole patient. But because we can't use end-tidals when we're oscillating, this is our alternative. So this is just a little bit, what do we do when certain things are happening to our babies? So what do you do to get called to the bedside, or you're at the bedside, or there's no R2s on your unit, I don't know. Your chest radial drops, your alarms are going off, and the baby's desaturated. Now, some people would say, if you have no idea what's going on, take them off and bag them, right? Like, it's always an option. If their heart rate's still okay, I would say, please don't. See if you can't do a little bit of troubleshooting prior. But so the acronym that we use is DOPE, and a lot of people, we just instinctively do all of this. Stands for displacement, obstruction, pneumo. I wasn't playing with my slides before, so. Oh. I don't know, pardon? Oh. Or hit it 5 times. Something will work. So displacement. The easy one is your baby's crying and your tube's out, right? Oh. I put this picture up because it is kind of hard to see, but there is a bevel on at the end of every endotracheal tube, and we've started. Was a little bit different. We started paying a little bit more attention to that because, particularly when we're using the jet, so you can see a little bit on this X-ray, the bevel is right there, and we have to make sure that. It's not at the carina, it's not just, the bevel isn't sitting at the carina with the air just going into one lung or the other. Does that make sense? So we will, sometimes you can see it on X-ray, sometimes you can't, and we'll bring a second tube to the bedside and we'll look at the markings and see where it is in the mouth and try and figure out which way the bevel would be inside the baby. So it's certainly one thing we consider when we talk about displacement. And then of course, this is a lovely right mainstem intubation, so another obvious displacement. Oh. Obstruction, so secretions is everybody's number one. You of course can have kinks in your ETT, you can have kinks anywhere in your system, or blockages anywhere in your system that are gonna cause your baby not to be able to ventilate as well. This one is supposed to be showing, we don't always think that the little black part in my suction catheter, if it's left too far down, it obstructs your endotracheal tube. And not everybody pulls it all the way back into the sheath. So it will also impede your ventilation. So just a really quick check. Then you have your pneumos. This is just a transillumination. Transillumination, a baby on CPAP, as you can see. And then a large right pneumo with a shift of the heart as well as the trachea. I don't know, I'm not letting it touch my slides again. The last one is equipment. So you always gotta make sure everything's still hooked up right. A lot of times, little things can come unhooked on your ventilator or your oscillator, and it can make a huge. You won't hear it necessarily. Sometimes you can't even see it right away, but that. Whoa. Okay, how do we involve the families? I think we all just need to answer them as best we can and as honestly as we can. Try and keep it all simple, as much as that's possible. One thing we do a lot is containing our babies during all procedures and all handling. So that's a great way to involve the parents, is just have them on the other side. They contain during suctioning, they can even hold their feet while we're retaping ETTs and talk to their infants, and comfort them that way. And then kangaroo care is something we're going to do with all our patients whenever possible. Something I've never done on a sensormedics. That would be a little bit difficult, but they can certainly hold on the sensormedics and just don't. Anyhow. And then this did not show up right. It was just, but it's nobody's fault. So it's just talking about sort of the differences between all of them as far as bedside care. So the easiest to manipulate is high frequency on a ventilator because it's going to be the same as manipulating any other ventilated patient. The jet is moderately or slightly more difficult just because you have to keep, the box has to be positioned just so, you have to make sure the pressure line is facing up, that type of thing. And then the sensormedics is absolutely the most difficult, right? You have those very stiff tubings, they have to be in line with the baby, you have to keep them level, so much, much more difficult. The jet and the high frequency on the ventilator are both very, very quiet. The sensormedics is very loud in comparison. What?
Not for the baby. The jet is very loud for the baby.
Louder than the sensormedics?
It's very, the noise box is quite loud.
Yeah, not louder than the sensormedic.
It's going to
probably, yeah. The ventilator's the quiet, then the jet, then the sensormatics. How's that? For the sensormatics, you must use the transcutaneous as well as the jet, and then on the ventilator, you can use the DCO2 to manage your, to try and trend your CO2s. I can't remember what else I had on there, so that's good enough for now. Side rests. This has been talked about a little bit. When to use them, why to use them. All it is a conventional breath, a positive pressure breath during oscillation. Generally enough pressure to move the chest, generally a little bit higher eye time. So the rate, if we're going to do it, is set really low. Different reasons, different people will ask us to do it. For recruitment, Evan talked this morning about when you put a patient on the jet, you start with a low rate just to recruit some alveoli and then slowly turn it off. Sometimes we're asked for the right upper low flaps, and some physicians prefer it, whether that's experiential, whatever the reason is. So this is a baby with the right upper low flaps. And something we don't always think about, because almost, I don't know, a lot of our babies have a right upper low flaps. And sometimes the question is why? So if we look at the anatomy here, the right main stem goes much straighter than the left main stem. So that's why we always get the right main stem intubations. But if we think about air wanting to go the easiest possible route, the way you get to the right upper lobe right here is much sharper angle. It's way easier to go everywhere else than it is the right upper lobe. So potentially that's maybe why the right upper lobe is what we are collapsing often. I don't know if that's typical experience. And then again, if they have PIE or a pneumothorax, I would use caution. If there is weaning on rounds, I would suggest that maybe we try something else rather than a SIGH breath. Oh, I'm supposed to say extubating, weaning and extubating. So you can extubate from the oscillator or the jet. I think previous practice was always to want to change to conventional just because we knew what numbers we wanted the baby to be on. It felt way more comfortable. We certainly can do it from the jet or the oscillator. When you talk to people who have done it a lot, it's ensuring that your mean is something that you can deliver non-invasively. You don't want to extubate from a mean of 20 if you're not going to be willing to non-invasively give a mean of 20. And then the most important thing, I guess, is babies do not follow the rules. They're not a one-size-fits-all. Every baby's going to be different. And one thing I know for sure is sometimes you just got to trust your gut. Sometimes you've tried everything and somebody will come in and they'll say, why don't we do this? And you don't know why, you don't know how it's going to work, but it just seems to work. I didn't really talk about kangaroo care too much, but we do it on all our infants and we encourage it whenever possible. And I know I've heard of late that we don't do it with patients on the jet, and that's a myth. We've talked a lot about myths. That's unknown, right? It's a new practice. It's a new machine. We're not sure about it, but there's no reason that babies can't be held when using the jet. We did a stand and transfer last week 3 or 4 times with a mother and her baby on the jet, and it worked perfectly. So it's a matter of having good conversation with your coworkers, your nurses at the bedside, the parents, and ensuring you do it safely, just like you would any other patient. I knew it would be done. So I was hoping that maybe other people could talk about their experiences, or if they are having significant right upper lobe classes, if that's something other people are having issues with and what they're doing about it, what's your doing about the noise levels, anything. No, nothing? Okay.
That's it.
Hmm?
That wasn't
I
too
didn't
fast.
think there was going to be that one. Huh?
Good. Any questions?
I never have. We don't